Okay, Rashir, go ahead.
Good evening, everyone. It gives me great pleasure to welcome you all to the SSAT webinar on modern surgical training for residents. We have a fantastic panel of speakers today who are leaders in surgical education. Next slide, okay. Just a few housekeeping issues before we get started. Please mute your audio to minimize disturbances from background. Also, the recording of the webinar is going to be available usually in the next 24 to 48 hours. And once the recording is available, we will send an email out to you so you can view the webinar. In addition, you can subscribe to the SSAT YouTube channel where the recording is going to be available. Keep going. Just one word about membership. You guys all know there are numerous surgical societies, but I can tell you from personal experience that SSAT is probably one of the most affordable, especially for trainees. The membership fees for trainees and medical students is only $20 per year. And in addition, the registration to SSAT and DEW meeting is usually complimentary, which is humongous, especially since things are so expensive these days. Also, we have the Journal of GI Surgery, which is the official journal for SSAT. As you all know, it's a very well-known and reputed journal. And we also have an SSAT podcast that is available across numerous platforms. So now, without further ado, let's get started with the webinar. I'll turn it over to Dr. Saad, who is my co-moderator. He's the program director of surgery at University of South Florida in Tampa. And he's Dr. Mellinger.
Thanks, Rashir. I can't tell you how excited we are to have this wonderful panel of speakers. The first of is Dr. Mellinger. He is the endowed chair of surgery at Southern Illinois University. He's won multiple teaching awards, including Educator of the Year for CMDA and Teacher Award for ASC. For those of you who have not had the pleasure of hearing him speak, he's amazing and a true pioneer in surgical education. So without further ado, Dr. Mellinger, thank you.
Thank you so much for the gracious introduction and the privilege of being part of this SSAT webinar. We're going to talk about the trials and tribulations of modern surgical training. In this opening session, I have nothing to declare by way of disclosures. As you will have noticed in signing up for the webinar, the purpose of this talk is to really set the stage, and we're recognizing that much has changed in the last couple decades, and we want to think about the challenges that our trainees face as they navigate their career development and set the whole discussion up in a way that others will then be able to help us understand ways forward and ways to optimize the training for those who will be following us. One of the best summaries that I have heard in recent years came from Frank Lewis, past executive director of the American Board of Surgery, in a talk he gave in 2015. And in that talk, he emphasized some of the key challenges facing the current generation of trainees. And we'll cover some of these in more detail, but these included the fact that there's some variation in the product coming out of a diverse set of training sites, over 300 now nationwide. That the medical school preparatory experience has been compressed by curricular mandates and pressures at the undergraduate medical school level that have affected preparation of students for their residency. There have obviously been huge transitions around the technology through which we practice, including laparoscopically and robotic techniques, and faculty learning curves as they navigate their index experiences with those post their own training. The impact of the duty hours, we all recognize some real benefits that have come from that, but it did decrease the average 5-year residence training time by 6 to 12 months if you add up the hours that were spent prior to the duty hour regulated era, and in particular impacted night and weekend duty, which in many programs historically was where residents really picked up a lot of their opportunity to develop autonomy skills. There's obviously been a whole change in the ethics around the care of underserved populations. That's been a good thing, but it has affected resident experience. A lot of economic and regulatory pressures, and then the whole issue of fellowship training and the fact that the vast majority of our trainees are now specializing. And the bottom line is that all this means we are fitting more and more complex things into a smaller container in trying to train the current generation. Let's see. Sorry for that. A few years ago, as a program director, I sketched out some of the pressures I felt I was dealing with that felt different from the time when I trained. And I just listed them on this slide, and I won't go into all of them, but I think you'll see that whether it's regulatory or economic or curricular or leadership domains, there are a huge number of challenges that we're factoring into the training environment now that frankly were not present, at least in degree, and many of them even in presence from the training paradigm I trained in. And we also recognize that our residents are taking care of a very different patient population in terms of the acuity of the patients being cared for in the in-hospital setting. Pretty much in many of our training programs, pretty much anything that doesn't require in-house management is done through ambulatory centers and high production volume-oriented delivery systems. And that means that our residents in the hospital setting are not only compressed by all the things I mentioned, but also caring for a sicker group of patients, whether you measure that simply by their comorbidity scales or by the number of patients requiring intensive care, as these graphs show. And then you've got this whole issue of other changes, both current and trends. On the trend front, if you go back a century, it was estimated that medical knowledge took about 100 years to double. The current estimates is that may be happening about every 70 days. So our residents are dealing with an entirely different cognitive load, both to develop their skills and then to keep current thereafter. The pandemic, as everyone knows, has brought challenges around recruitment and interviewing in the match, around case volume, particularly with the chief resident class from this past year and the year prior, with ongoing challenges now related to the Delta variant, depending where you are. And our residents have become very much involved in doing work as part of their really a remarkable demonstration of the professionalism of the surgeon outside their training domain or focus, simply to meet public health need. There's the magnification that the pandemic has brought to our healthcare disparities and the inadequacies of our system. And then the professional things we're navigating around what the duty hours mean and how we as a profession are navigating our commitment to patients alongside our need and commitment to care for ourselves and keep ourselves sustainably strong to serve patients well and with compassion. So all these things, culturally and otherwise, have created a very complex playing field for the medical and surgical educator. The other thing I think it's important to keep in mind as we think about the sustainability part of the equation for our trainees is that while general surgery and the general surgical based subspecialties have really been in kind of the middle of the pack of all the disciplines, the medical disciplines in terms of burnout rates in a lot of prior work. If you ask people specifically about the balance in their life between their professional commitments and personal or family life, general surgery is highlighted in the bar graph to the right. This is from Shanafelt's prior work, actually ranks at the very bottom. So you put these pressures on top of that baseline data about what we do as general surgeons, and it clearly creates a very complex playing field. The audience will all be aware of the various ways this has led to questions about the training model and the end product. The Matar study that was presented at the American Surgical and then published in Annals back in 2013 that suggested that somewhere around a third of our graduates couldn't do a laparoscopic cholecystectomy independently, at least in the eyes of fellowship program directors, and or couldn't be left and expected to progress on a complex case left by themselves, and then other measures, both in the surgical literature, peer-reviewed literature, and in the lay press, have called to question whether we are navigating these challenges in a way that's serving our trainees and ultimately the public optimally. This is from data from the American Board of Surgery, taken back in an interval ending in 2016 around certifying exam performance. And you'll see that there's quite a scatter, quite a bit of variability. And in fact, over a third of programs actually had at least a third of their residents fail to pass both the written and the oral exams on the first take, suggesting again that there's quite a bit of variability, at least as measured through cognition and judgment, as those exams are able to assess them in our end product. If you look at more recent data from the Simple database, this is residents in their last week of training, over 500 residents, 400 attending raters, 10,000 data points. And they're asking specifically the question, are these residents able to function autonomously on a variety of cases in the opinion of their faculty member, again, in their last week of their chief residency year? And what you'll see is that the rates are in the 90% range for most of the common procedures, but it drops off if you get into less common procedures and is as low as the 69% range, for example, for core procedures that aren't common, such as splenectomy. So it suggests that even by way of operative data, our residents are not graduating with the ability to do all the operations we think they need to be as we're assessing them themselves, at least as reflected in this database. The other thing I think to keep in mind is that all this is important because the things that we are formed with in our training years do translate into our long-term performance. This is data from a study Rachel Kells at Penn published back in 2016 that looked at patient care outcomes, including prolonged length of stay, failure to rescue, overall complications, and mortality, operative mortalities for a number of operations, including common ones such as appendectomy, as well as more complex ones such as pancreatectomy. And they related this data through database intersection with the residency training program of origin. And what they showed was, in a statistically significant way, you could group our graduates by tertiles, and that there were statistically significant differences in their outcomes on these very important parameters. So it suggests, again, that we're being formed during the training years. Those things translate into our patient care, and we need to be thinking about the training environment and how to make it more standardized and better equip our trainees for the world in which they're going to function. Obviously, a big part of the movement that has been under discussion in recent years, since the time of Halstead, as pictured on the far left in this picture, and Flexner next to him, to the contemporary era, is the move towards a competency-based focus. And my main comment here is that while this represents, I think, a useful way to rethink our training paradigm and honor our public trust, it also has added layers of assessment and regulation to the training model for our faculty that are increasingly complex and do take significant time from other things that we would like to be spending that time on. So it still may be the right thing to do, but it's not without its challenges in terms of development and execution. In reflecting on these things, one of the things that struck me, and I wrote about this in an editorial this past February for JAX, was that our training model, because of the significant increase in volume of knowledge and skill that's required of our trainees, has become maybe a little bit homuncular in that we are focused so much on those things. I think we've stopped thinking enough about the third Aristotelian quality, if you will, of the learner, and that's character or virtue or who we are and how we're training people to run from a sense of meaning and purpose the marathon of a career. And this is underdeveloped, I think, in our current training primes because of all these pressures. And that's not without its cost. This is a reflection from a transitional intern at Yale that was published in JAMA Internal Medicine in 2018. And you're just highlighting that the push of his training environment was centered on achievements that are reflected in a CV, but were actually keeping him from spending time on his own development as a person, and indeed stunting his continued growth in that, even though it had a great deal to do with how he showed up at a bedside. And this is another challenge that our trainees are facing in this environment, again, related to this myriad of pressures. And I would submit to you that our failure to figure out ways to incorporate that into what we do with our trainees is potentially very costly from the long-term career standpoint. This is a paper that a group of us from SAGES published this past year, focused on lessons we were learning about from the pandemic, about the burnout pressures in our profession and what it would be like to have an offensive strategy around the joy of what we do and not just developing resilience and defensive strategies. And what we found is that the things that bubbled up in the discussion were things that involved these more character-based or virtue-based qualities, things that were timeless, that involved relationship, and that involved a heavy focus on the meaning in what we do. So again, how we factor all this into a very complex training environment is part of the current pressure. So I'll just summarize this before we move on by saying that our trainees are in a much more complex environment than we were in, and that the cultural defaults of our profession and our education system are being challenged by that in ways we are not accustomed to. The trainees themselves, I think, and the pandemic has really highlighted this, have been incredibly resilient and are a critical voice for us to listen to in making substantive change and in factoring in these pressures and how we go forward. And we need to be thinking about the sustainability of the model and not just making it current for the current pressures. So having said all that, I just want to say I'm very thankful that my job was to present the mess. And we've got people now who are going to help us sort that out and make our Mayo stand look a little better. I will stop there and look forward to the rest of the panel. And again, thank you for the privilege of being part of this tonight.
Oh, that was great, Dr. Mellinger. We'll see how much of the mess they can clean up here. But thank you so much for that. And I'm sure that'll we'll have a lot of questions for you at the end. The next speaker, who's going to be talking about robotic technology and how it affects the training paradigm these days, is Dr. Cannon, who is someone that is very special to me. She was one of my mentors in Birmingham at UAB, and taught me everything I know about the robot. She's a colorectal surgeon there, probably one of the busiest academic colorectal surgeons in the country. She played a primary role in creating the robotic curriculum at UAB, which UAB was an early adopter of the robot, and so the curriculum she helped create has really been a template for curriculums all around the country, and I think people are still using that and building onto it. She's also the program director of the colorectal fellowship there in Birmingham. So without further ado, Dr. Cannon, thank you.
Thanks, Adam. Thanks for inviting me to talk tonight. I will go ahead and start sharing my screen here. All right, so as Adam said, I'm going to be talking about robotic training for our surgery residents. These are my disclosures. I'm an instructor for Intuitive Surgical. So when I talk about teaching residents robotic surgery, there are three main challenges that I get asked about most often. So we'll talk about all of these a little bit tonight. One is, as we just discussed, all the challenges that are there for residents and all the things that they're expected to learn during a 5-year general surgery residency. So if we're adding robotic surgery onto that, how are we going to make sure that they're also taught in laparoscopic and open surgery in addition to robotic surgery? And what about attendings earlier in their learning curve? As they're first getting started, how is that going to impact resident education as more and more people are learning robotics? And what if a resident goes to a hospital somewhere where they don't have a robot? Then have we wasted all of this time teaching them robotics when they're not going to be able to practice it when they're out? But before we talk about those things, I'd like to talk a little bit about how we are training our residents and talk about our robotic surgery curriculum, which I think is very important. At UAB, we are definitely committed to resident education. We're one of the early institutions to have a simulator that's available outside of the operating room all the time so that residents can access it at any time. And our residents do more consult cases on the robot than at any other institution in the United States. I think one of our keys to success has been that early on, we have put an emphasis on supporting high volume, low acuity cases. Obviously, the robot is a limited resource. And so there was question in terms of, should we be allowed to use the robot to do cholecystectomies? And we made the argument that it's important for a resident to be able to do these high volume, low acuity cases so that they get experience on the robot and they can learn on these cases before they're expected to staple off a pulmonary artery or do a low interior resection. And I would argue that this is really a selling point for our program. And I can say that I know this because when we're doing residency interviews and fellowship interviews, it is one of the things that we're asked about most often. They want to know about what their robotic experience is going to be during residency. This just kind of shows what our residents are doing. You can see that it has changed over the years. Thoracic surgery, because our thoracic surgeons were early adopters of the robot with some of their highest volume early on. But the general surgery, which includes colorectal surgery, got kind of started in 2010 and has now really exploded. So at this point, the vast majority of the cases that the residents are doing fall into the realm of general surgery, which includes foregut, bariatrics, colorectal, and then a little bit of surgical oncology. I think key to success in teaching residents is that you really can't just throw people out there and tell them, hey, teach residents robotic surgery just the same way you might laparoscopic surgery or something else. I think having a well-defined curriculum is very important. One of the things about the curriculum is it encourages the residents to make sure that they have done the pre-work that's necessary before they're prepared to sit on the console. So they know what the expectations are before they're going to become a robotic console surgeon. And so the expectations between the teacher and the student are understood at the beginning of every case. So what's required to be successful in teaching residents robotic surgery? A number of things. First, you have to have somebody that really is passionate about this and is going to make sure that the residents get this education and is going to monitor it and establish the curriculum. A simulator is absolutely essential, and we'll talk about simulation a little bit more. I think having dual console where the attending and resident can sit right next to each other and work on the case together is really critical. And I know there was one point when we were early on in our robotic teaching that we didn't have a bedside assistant. And I remember being told by administration, well, you don't need a bedside assistant. That's what your resident is for. That's not what our residents are for. They're there to learn surgery and they need to be sitting on the console. So having an experienced bedside assistant so that that task doesn't fall on your more senior residents is also important. It should not be overly burdensome for the residents. Mandatory times just can frustrate residents. And if they're putting in the time and spending the time on the simulator and really learning these skills, we have to make sure that they're also doing these cases so that they gain that experience. So our curriculum, the basic objectives of our curriculum is that when residents finish our program, that they'll be able to understand where the value of the robot lies, what cases are appropriate or not appropriate for a robotic case, what the advantages and disadvantages are. They should be comfortable with bedside, docking, exchange of instruments, and how the robot actually works. And they should have a basic understanding of camera movement, of clutching, etc. We do offer essentially a two-tiered program so that everybody that graduates from our program will understand those basics. And if they are interested in actually being an accomplished robotic surgeon when they're done and being able to perform robotic surgery independently, we have additional requirements for them. I think two key components of the education process is understanding that there are some safety issues that are unique to the robot. The main thing is that you don't have tactile feedback. And so it's incredibly important. You can't use your proprioception like you do in laparoscopy to know where your instruments are. You can never move an instrument that's not in view because you may not realize that you're injuring something else because you don't actually know where that instrument is, even though it may feel like it. So the basic components of our program, all the residents initially complete an online, the online intuitive training on the robot. And we then do workshops to introduce them to docking, instrument exchange, the basics of the console, and then how to use the simulator. The expectation on the basic level is that all residents will perform at least 5 cases as bedside assistants and complete all their simulator modules before they actually sit on the console. And then to graduate our program, they have to have been console certified for a minimum of 5 cases. I'm not going to talk very much about simulation because I know Dr. Smink is going to talk about that later. But I do believe that especially with robotic surgery, simulation is incredibly important. The video you're seeing here was my son many years ago when he was 6 years old. And I brought him in on a Saturday to practice on the robot. He's too little to reach the pedals with his feet, so there's no camera or clutching, but he's able to take control of the instruments and just kind of get it figured out. So I think if he's able to do that, we can definitely teach robotic surgery to our residents. But simulation is incredibly important. The time to learn how to actually control the robot is not when you're operating on a patient. That is done on the simulator. So by the time you're actually doing your first case on the console, things such as camera movement, clutching, that should just be pure muscle memory. You shouldn't be having to think about those things. And since I showed that picture of my son, I show a picture of him now. He's now taller than me and 16 years old and is now my scuba diving buddy. So, and simulation continues to improve. So we now have newer modules that actually mimic a true operation rather than just working on the skills. So there's a module where you can go and practice doing a hemicolectomy with an intracorporeal anastomosis, or practice doing an inguinal hernia with your mesh placement. One of the things we do to encourage our residents to get on the simulators, we do a monthly competition. This is across multiple disciplines. So this is not just general surgery, but it includes GYN and it includes urology. And each month there's a different simulator module that the residents work on. And then there's a winner at the end of every month in terms of who got the highest score or the shortest time they were able to complete it with a score of 100. Basically, our interns do work on the simulator, do basic docking, bedside assisting. They will usually by the end of the year get a couple of cases on very simple cases. And then our second years are doing cholecystectomies and hernias. They get introduced to foregut, bariatrics, thoracic, and just recently here, transplant surgery during their third year. And then in their fourth and fifth years, they're doing the more complex surgery, continuing with more advanced foregut and bariatrics, as well as colorectal and adrenal surgeries. This just demonstrates the volume of our residents, so that you can see our chiefs in their fifth year average approximately 30 robotic cases per year. And about half of their cases are colorectal, and the other most common ones, gallbladder and hernia, and then adrenal, and increasingly now is foregut and bariatrics as well. I mentioned we have the two-tiered training program. So residents that want to do robotics, which is the vast majority of them when they are done, have more complex simulator modules that they're also required to finish, and have to do a total of 30 console cases, which is slightly more than what is required by Intuitive. And we then give them a letter documenting their robotic experience, and then they get the certificate from Intuitive as well. We also require that 5 of their cases during their chief year essentially be proctored cases, which just means that at the end of the case, they review the case with the attending surgeon, go over what they did well and what they didn't do well, and they essentially have to be signed off by the attending surgeon to say that they are competent on the robotic system. So to talk about the challenges that I mentioned at the beginning. So how do we teach all of these modalities, robotics, laparoscopy, and open surgery? In order to answer that question, I think it'd be interesting to look at some changes that have occurred since robotics came up. If you look at prostatectomy, which was really what brought all the robots into our institutions. Back in 2004, robotics was just sort of emerging, and 12% of prostates were performed robotically, while the rest of them were performed open. By 2017, only 12% of prostatectomies were performed in an open fashion. So we greatly increased the amount of minimally invasive surgery. But interestingly, you also see 6% being performed laparoscopically, which is not something that was done prior to the introduction of robotics, or at least not very often. Benign hysterectomy, 42% used to be lap, the rest open. And now you see that there's actually this slightly more cases being done lap, but then also the addition of robotics, so that now only 25% of cases are being done open. For malignant hysterectomy, 92% used to be open, and now only 12% is open, as that has been replaced by robotics. For rectal resection, what I do, so previously 24% done laparoscopically, and interestingly, more recent data shows that the number being done laparoscopically is almost the same, but robotics has taken a big chunk out of those open operations, so those are now being done by a minimally invasive approach. So I think the take-home message here is that open surgery is decreasing, but I think that is actually probably a good thing. Residents are still going to get plenty of experience in open surgery, but increasing the amount of minimally invasive surgery should be a goal for all of us. As of right now, although this will probably change in the future, laparoscopy is not really being replaced. As a matter of fact, with some operations, the introduction of robotics, we're actually seeing an increase in the amount of laparoscopic surgery as well. And I can personally give some anecdotes as how that's true for me. Things that I wouldn't have attempted to do laparoscopically before, such as an intracorporeal anastomosis. I've now done it so many times and was so comfortable doing it robotically that if I'm in a situation where I don't have a robot, I will do the anastomosis laparoscopically. Things that I would have done open before. If I'm on call and I've got a perforated gastric ulcer, I don't have the robot, unfortunately, at 2 o'clock in the morning, as much as I would love it. But because I'm more comfortable just with a minimally invasive approach overall, I'm now comfortable doing that laparoscopically, where before that would have been open. So I think there's a lot more overlap in terms of the robotic and laparoscopic skills than we recognize. So I hope that because of that, this controversy between laparoscopy and robotics will go away over time. I also think that the two are going to merge. As the technology continues to improve, there's going to come a day where we don't discriminate or we don't differentiate between laparoscopy and robotics, because they're all the same. We just have robotic technology in our laparoscopic operations. And along those lines, if you look at our residents and their total number of cases, this is divided up by PGY year. So they graduate with 92 cases on average out of 1,133 cases. So while they've got an amazing robotic experience and the best in the country, that still only represents 8% of their overall operative volume. So they're clearly still getting experience with laparoscopic and open surgery. One of the other challenges, what about attendings early in their learning curve? As they're learning, is that going to interfere with the resident's ability to do these cases? And I would argue that the robot actually just makes teaching so much easier, that this is not a huge concern. Looking at this operation, so starting a low anterior resection, the first step is setting it up. And I believe that an attending and a resident get different things from the case. So even if an attending is early in their learning curve, there's still parts of the operation they're able to let the resident do in order to learn the operation. So what the attending is trying to learn is the interaction of the instruments, where they run into challenges because they collide, how they set things up. So the attending, even when they're first starting, can very much set things up, but then they get to the point where it's just plain operating. You're pointing out the anatomy to the resident that's trying to learn the planes, etc. And the robot makes that easier to do. When you have the dual console, it's very easy to switch instruments back and forth, so that if the resident gets to a point where they're starting to struggle, that they don't have good things aren't set up well, and they don't have things exposed well. That's compared to laparoscopy, where you've got to switch sides of the table, and it's a big deal to make that change. It's very easy just to switch control of the instruments back and forth. So I can take control of the instruments, reset things up, demonstrate to the resident where the planes are, and then turn it right back over to them. So I'm not taking more of the case away from them. Along those lines, what I think this will be very interesting in the future to see what we can learn about teaching robotics. So there's the new My Intuitive app that will show you all of your cases, and it shows you the time that was spent during the case, which when I look at my case times, which are above national average, actually at first made me feel really bad. I'm like, oh, they're trying to make me feel bad that I'm slow and I take a long time. But it also gives you information about when you have control over the instrument. So this made me feel a little bit better about it, because I can look at this case, so doing a low anterior, and you can see here the times that I was controlling the instruments as compared to when the resident sitting next to me on the dual console was controlling the instruments. And you can see that they had control of the instruments the vast majority of the time. And I think that having this data will be really interesting to look at in the future, so that we can see, how much time does a second year have the instruments doing a gallbladder as compared to a fifth year? Do they have the instruments the entire case? So we can see who is really doing most of the case. And we can also use this to evaluate our educators. Are you just doing the case yourself, or are you actually letting the resident do the case? So I think this will be a really interesting thing to look at in the future. And then the last challenge that I'm often asked is, well, what if a resident goes somewhere and they don't have a robot? What are they going to do? Are they going to know how to operate without a robot? And we already discussed how I believe that learning robotics can help you with laparoscopic surgery as well. But I'd also like to point out that the chances of them going somewhere where they don't have access to a robot are actually pretty remote. If we look at this slide, and this is very old, so this only goes through 2010, but when we got our first robots in the United States in 1999, you can see there are 2 robots there. But as we go year by year up through 2010, you can see the exponential growth as robots just were showing up all across the country. And again, this volume of robots, that only goes up through 2010. And currently today in the United States, as this is from 2019, there were 3,570 robotic systems in the United States. And there is not one academic program in the country that doesn't have access to at least one robot. So I would argue that teaching robotics for residents can actually help improve their laparoscopic skills in addition to their robotic skills. And it's very unlikely that unless they go to a very, very rural, remote area, that they wouldn't actually have access to a robot. So to summarize, I believe we have an obligation to teach robotic surgery to our trainees. I think having a formalized training curriculum definitely breeds success. Simulation is key. Again, you need to know how to work the machine before you actually operate on a patient. I think using the robotic platform actually makes us better teachers, and it can absolutely be part of a training program without hurting or impacting the other ways that we operate. So thank you very much. This is my email address. I welcome anybody to reach out, particularly about the robotic surgery curriculum. If you're interested in our curriculum, if you're working on developing yours at your institution, send me an email and I'm happy to share that with anybody. So thank you.
Thank you, Dr. Cannon. That was a great talk. And I love the highlight that you made about the percentage of operations that the trainees are doing robotically. It would seem that robot is completely taking over. It's all robotic, and in your institution, less than 10% of overall case volume is robotic. So I think that's very important, and it helps keep things in perspective about the technology and the use and the value going forward. So our next speaker is Dr. Doug Smink. He is currently at Brigham Women's Hospital, Faulkner campus, where he's the chief of surgery. His research focuses on resident and faculty education and how to teach communication, leadership, and decision-making among surgeons and surgical teams. He serves as the chief editor-in-chief of Journal of Surgical Education and was recently selected by the American College of Surgeons to the Academy of Master Surgeon Educators. Dr. Smink's talk today is related to simulation and video critique. Dr. Smink.
Thank you so much. It's really great to join this panel. I've learned a lot already. I look forward to the rest of the talks. I get to speak to you now about simulation and video critique for surgical trainees. I don't have any disclosures. I do try to summarize my talk in one slide now. It helps me sort of hone down on what I want to talk about. I think it's also helpful for those of you, if what I'm about to talk about doesn't sound so interesting, you have 10 minutes that you can spend on your phone or checking your email. I'm going to try to convince you in the next 10 or so minutes that it's time to modernize surgical training, and that video and simulation are the future, but actually should be the present of our training programs. Now, Dr. Mellinger touched on this a little bit, but I like to frame my talk in thinking a bit about the challenges that we all face in surgical education. We know there's been this amazing explosion of knowledge and technology. We are all increasingly subspecialized, and that's true of us as faculty. It's actually true of our anesthesia colleagues and our nursing colleagues, and it makes it incredibly challenging for us to teach the broad specialty of general surgery. There's an increasing financial pressure that we're all expected to produce more in less time, and the quality imperative that we need to do this with the highest possible quality. And now our data are even being published both internally and externally. And all the while we do this in these dynamic interprofessional teams. This is a concept that I really think is truly essential to our training of surgical trainees, and I think is really an important part of simulation. So I'll talk some in a bit about how we make sure that we prepare our trainees to be in these interprofessional teams. Now, Dr. Mellinger talked about this very paper himself, going into fellowships, could not do a lap chole, and 2/3 of them could not operate in an unsupervised fashion for 30 minutes. Now, I think those of us who train surgery residents might disagree with these data, but this is out there, and this is some of what we're challenged with. So I like to ask people, is this where we're headed? And I would strongly say no. I'm frequently asked by people, particularly surgeons more senior than me, who will ask me, do you really think today's residents are as good as they were in the past? And I actually like to tell these people that I think the residents are better. I think our residents know so much more than we did a couple of decades ago, and 20 or 30 or 40 years ago. We have new disciplines like minimally invasive surgery and critical care. We have new diseases and treatments that we had never heard of before and never put into action before. We expect them to be expert in all the core competencies, and we don't just focus on patient care, but things like professionalism and systems-based practice and quality improvement. And as I think many of us in education know, our residents often know more and our students often know more about these topics than our faculty do. I think one of the challenges is that as we have eroded autonomy somewhat in our training programs, the trainees don't know that they're as good as they are, and actually we as surgical educators don't know as well. Now, I think as obviously duty hour reform came in quite some time ago, but I think the initial reaction to some people was that if we're going to have duty hour reform, we're just going to have to make training longer. So this is, I would disagree with that as well. And I think this is a call for innovation. This is Henry Ford. And I love this quote from Henry Ford, who said, if I listened to the customers, I would have given them a faster horse. This is where we need to innovate, and we need to think about better ways to do things, not just a longer training program, for instance. So when are training devices useful? Here's a list from 1970 about when training devices are useful. So when there's a high level of difficulty, where there's high criticality to what you do, where there is infrequent chance to practice and difficulty of teaching in the real environment, where there are safety factors, and there's a high cost of using equipment for training. Now, this was not written about the operating room, but I think we can all agree that this is clear support for the importance of simulation in surgical education. Now, one of the beauties of simulation is that it's actually okay to fail. And you can practice and do it again and again, just like you would in any other part of your life. That's something you're trying to learn, a new skill outside of your professional life. And the beauty of simulation is that we can practice it and we can do it again and again until we get it done correctly. Now, Dr. Mellinger talked a little bit about technical skill and surgical knowledge, but also that third aspect that's really important. And I think, and that's actually been a real area of focus for me in our training program, to focus on what we call non-technical skills. So obviously technical skill is important in surgical training, and we have a lot of parts of residency requirements that focus on technique. So we have a certain number of required operations in defined categories. We have mandated curricula that focus on laparoscopy and endoscopy. And we have a requirement, as many of you know, for assessment of surgical trainees on their technical skill in the operating room. I'm not here to argue that technical skill isn't important, but I do remember being told as a trainee that we can teach a monkey to operate, but can we teach them to think and to act like a surgeon? So part of my focus in surgical education has been on what's called non-technical skills for surgeons, or in this nomenclature here, NOTS. And I've had the privilege of working with an organizational psychologist, Stephen Ewell, who basically has studied surgeons. And he studied what makes us excellent at what we do. And he's pointed out that in addition to surgical technique, there are non-technical skills, the cognitive, how we think, and the social, how we interact skills that really underpin excellence in surgical performance. So we like to think with trainees about situational awareness, your knowledge of what's going on around you, both in the operative field, what structures might be lurking behind the tissue that you're working on, but also in the operating room. Who's in the operating room? What are their capabilities? What's going on around you? Decision-making, how do you take that situational awareness and do you make a decision? Because I think we all know that the importance of making a decision, both a decision to operate, but also a decision on how to proceed in the operation, are so essential to a safe operation. Leadership is a really core skill in and out of the operating room for surgeons. And then communication and teamwork. And how do we interact with our team? And how do we help our team achieve and perform at the highest level in the operating room? So one aspect of simulation that we focused on a lot is actually operating room team training. And I work with a group across multiple institutions here in Boston. I'm lucky to work with people at all these hospitals and simulation centers. And actually, we've been supported by our malpractice insurer, CRICO, to bring these teaching hospitals together and build a multidisciplinary operating room team training program. So we train surgeons, anesthesiologists, nurses, and technicians all together in a simulation setting. to work on those non-technical skills that I talked about. What do we teach them? Well, we teach them teamwork, and we teach them leadership, and we teach them how to exert those within a team. We teach about closing the loop in our communication, and we talk about how to speak up and be assertive for patient safety. We also talk about how to create an environment where other people are comfortable speaking up so that we can flatten the hierarchy. And we even talk about something that seems simple, like the safe surgery checklist, but we know that data show that if the checklist isn't taught and retaught in practice, just like anything else, our performance of it diminishes. This is a video that might look like an operating room, and it is like an operating room, but it's actually in our simulation center. The patient here is a mannequin. We have a surgical team in one of our simulations performing this operation where they're trying to resect what they think is a tumor, but it's actually a plum. It's in a bowl of Jello, and we're able to control behind these this one-way glass. We're able to control bleeding. We're able to control the hemodynamics. And what we do is we put a surgical team in here, and then we see them just behave like they normally would. And you can see these surgeons and anesthesiologists and nurses are doing what we do every day. And then actually we stop the simulation and we debrief, and we sit in a conference room and we talk about what we do. We talk about that case, we talk about cases like it, and we teach ourselves, one another, how to be better, particularly in our non-technical skills. We've been able to write about this, and we have a pretty extensive experience with it now. We've expanded it beyond those 4 hospitals to our entire system. And although it initially started at the attending level, we've expanded this. So our surgical trainees and our anesthesia trainees and our nursing trainees work together in a similar program where we focus on their non-technical skills. That's not to say we don't have simulation for technical skill as well, but we have found this to be a really essential part of their training. I thought I'd turn a little bit beyond simulation to think a little bit about the future of where we're going in surgical training and how video might be part of that. I would guess that many of us have read some of Atul Gawande's work. He happens to be a colleague of mine. And this is an article of his about his experience with coaching now 10 years ago that he published in the New Yorker. We've actually taken this and expanded it to develop a surgical coaching program, a peer coaching program, initially with faculty, and now one that we're building with trainees. The concept of this is on the right side of the screen. The concept that during training, your surgical performance has a very steep learning curve. And then in early practice, you could argue it maybe flattens out a little bit, but it's still relatively steep. And the hope is that during most of your career, you'd continue to improve, but probably not at the same rate that you improved in training or early practice. I won't get into the late career discussion, but the goal of our training program is to help people who are achieving at a high level to achieve at an even higher level and to reach toward mastery, with the concept and the thought that, yes, we're all hardworking, intelligent, driven individuals, but if we really want to get to our best, the way to do that is to have somebody help us, and a peer coach is a fantastic way to do that. Now, we're not the first program to do this. Here are a number of programs that you may be familiar with. I would say Wisconsin and Michigan and Illinois are some state collaboratives that have led the way in this form of coaching. But we have a program now that's about 3 years into existence called SCOPE, Surgical Coaching to Optimize for Operative Performance Enhancement. And this current or most recent year, we, across 8 hospitals in the Boston area, had 90 surgeons, multiple specialties, pairing up where we train them to be a coach and we train them to be coached. And then those surgeons go into the operating room and observe one another and then have coaching debrief sessions. Now, right now we're doing this in person, but there is certainly a plan in the future and an ability to do this through video. And I'll just share that at the residency level, this has been successful in a number of other institutions. So here's a paper out of Toronto where they use video coaching of their senior surgeon on their laparoscopy rotation. they randomized them to either receive this video-based coaching or just sort of the normal performance or the normal teaching that you would get on a rotation. They showed at the end of the rotation that their surgical skills, their technique was improved when they had a coach during their rotation. And then here's something that we looked at with our own group, looking at operating room teaching versus video-based coaching. And I think this really helped us drive home the importance of video. What we did is we videotaped operations with the surgeon and a resident, and we observed those operations in person to determine what type of teaching occurred and how frequent was it. And then we had the surgeon and the resident within a week of that operation sit down together and watch the video and see what the teaching they did then was like. And you can imagine the stress of the operating room led to obviously important teaching, but it was focused a lot on technique and anatomy. It was not focused so much on those higher level concepts of decision-making, situational awareness, how you move a case from start to finish. And we found that level of coaching using video was at a level that I think we all aspire to in the operating room, but it's very hard in that environment. And it was really complementary, but different than what we teach in the operating room. You may be familiar with this technology, which is coming down the road and is being used in more and more institutions, both in the US and Canada and around the world, which is the Aura Black Box. The Aura Black Box, also developed by Tailor Grantroff in Toronto, is a video audio capture system in the operating room, which can capture both the operative field, whether it's laparoscopic, robotic, or open, but also the entire operating room. So there are two sets of video feed as well as audio, with great potential for video review after a case, which is part of what Taylor's group is doing, but also for development of a video library for trainees. And I think one thing that many aspire to is the ability to generate video for yourself as a resident when you do a case, and then review it yourself. But also, in an ideal world, you'd have a surgical coach in your training program who would help you go through that video and accelerate your learning curve. So I'm going to stop there. Hopefully I piqued your interest a little bit about the role of simulation, non-technical skills, and video in surgical education. Thanks again for inviting me, and I look forward to the rest of the talks and the discussion.
Thank you so much, Dr. Smink. That was wonderful. I'll have to come up to Boston and get some coaching from you. Move on to another Boston surgeon. Dr. Morales is a bariatric foregut and advanced endo surgeon at MGH. He's a co-founder and director of SAIL, which for those of you who don't know is the Surgical Artificial Intelligence and Innovation Lab at Mass General Hospital. So he has done a lot of research that's focused on utilizing computer vision to investigate intra-op phase of care and surgical analysis, all with the goal of improving care. I'm really excited to hear this talk. Thank you very much for being here, and we'll sit back and enjoy.
Thank you, Dr. Saz. A huge pleasure to be here. I wanted to thank you, the organizers at SSAT, for this amazing opportunity. Let me get my slides here. So when I talk about artificial intelligence and also, of course, the future of surgeons and the surgical training, so it's very important to understand, those are my disclosures. What is artificial intelligence, right? If you go from the basics, just by definitions, AI is a study of algorithms that give the machines the ability to reason and perform cognitive functions like we do. And dates back from the 1950s, 1960s. Then the other one is machine learning. And what is that? So algorithms that improve themselves automatically through data analysis and experiences, and different types of that. And I think that's very important about computer vision. That's how the machines understand images and the videos. So examples are, in our reality, the IBM Watson and the Tesla Autopilot. That's actually bounding boxes, pedestrians, and cars over there. But also the thing that we automated dreams and you see in the Marvel movies, such as Jarvis from Iron Man, and now there's called super or general AI. But the question is, what is happening in surgery? Are we actually seeing that surgery is happening in the same fashion and evolving at the same speed as the other ones? So give an example. Just in healthcare, the market is growing about 42% a year and is expected to be more than 100 billion by 2028. Another very interesting study that was done by Oxford and Yale, they went through the world asking experts about when human jobs would be replaced by machines. And if you look right here, right in the middle, surgeons ranging something between 20 to 80 years, median like 45 years will be replaced by machines. And again, there's a tiebreaker here. Surgeons in Europe, 46 years, in North America, 41, Asia, 31 years, which is kind of intriguing to think about that. Others, I think about that surgery could be replaced by machines. But what is happening now that wasn't happening in the past that is really changing? First of all, have a lot of access to data. And couldn't be a better talk to follow for Dr. Smith, talk about video data. So you can talk about video for coaching, but also think about video for training AI. So we have much more powerful computing processors, much more powerful algorithms as well to move forward beyond the data. And I give some examples that we already have in place. For example, this is a very elegant study done by Stanford and was published in Nature, where you can see that the machine was trained to understand and diagnose more than 2,000 different skin diseases. That was compared with expert pathologists and was a part of the results. What about video? This is a company from Canada called AI for GI, where the machine is able to identify polyps and make predictions about the probability of what class of polyp we're dealing with. Like another example, even a type 2 polyp, 2 millimeters, you can see that the machine, just by scanning, you could barely see it in the beginning, right? And then get quite close there, and the machine finally makes a diagnosis or the prediction. So in the research world, this is not for prime time yet. That's one of our work at Mass General. We're teaching the machine to understand a surgical video in real time and make predictions of the next steps of the operation. For example, instance, this is a laparoscopic cholecystectomy, dividing all those steps from port placement through gallbladder removal and bagging. And as you can see, the bar from the ground truth and the bar for the prediction for the machine are very close to each other. You see predicting the clipping, and after that cutting, and so on and so forth. Now we are in the process of training the machine to understand also the critical view of safety. Another example here is a work done in sleeve gastrectomy, which is we call the surgical fingerprint. What happened is the machine understands what's happening in surgery, and it makes a log probability that's being represented by a visual color code bar in a stairwell fashion. So red means high probability, blue means very low probability. Any color in between is somehow probability. And I'm going to play a video that the first video was a normal sleeve gastrectomy. The other one was abnormal for the machine, and see how it behaves. So in the first case, you can see the machine already identified the port placement, made the prediction that would occur, liver biopsy followed that, which occur, made a prediction that the gastrocolic ligament will be dissected, which occur, and then the stapling, and move so on and so forth. And you see this very nice shape of this color-coded stairwell fashion that we call the surgical fingerprint. And this was a normal example. But now what happened is on the case 2, the machine faces a patient who had an open cholecystectomy in the past, and therefore there was omentum adhesion to the abdominal wall. The machine has never seen this before. So the predictions are quite hectic. You imagine the liver biopsy is going to occur, probably not, then predicts again. And it's not only until we are able to recreate the anatomy, the progression of the operation was seen as abnormal. So examples are case A was a normal case, case B was an abnormal case. And again, this was trained with a very small number of cases, and we have not trained the machines about abnormality. But for the fact that the machine can detect abnormalities already like a very important feature for machine learning. And when you look about those 20 cases, the ones that have a low log probability on the frames, they represented some alterations in the case, lines of adhesions, bleeding, revisions. So they're all seen as a low log probability cases. So another way to represent this in a real time, let's imagine a case goes absolutely fine, and then the machine generates a normal surgical fingerprint. The other option would be that then when a deviation was detected, let's say in this case, the common bile duct was cut, even though the machine was not able to interrupt the physician in real time, just by the fact that generating something like this, we should go back and watch the video, should go back and perhaps watch this patient a little bit longer in a hospital, or perhaps get a consultation to see if we need a second pair of eyes. Some of the potential applications immediately with systems like this is attending notification. For example, the trainee is near to a critical portion of the case, such as before transecting the ducts on a gallbladder procedure. Telementoring, somebody is in trouble or doesn't know how to progress for a surgery they've never seen before, or either would be in a novice surgery, it could be in the military, could also benefit from telementoring. And also a peer review for like M&M augmented video conferences, or for credentialing and re-credentialing for hospital administrations. So that being said, showing some applications of artificial intelligence that's already in place using video, and also making the illusion of what can we be seeing in the near future. For us, especially the trainees, it's very important to understand what are the obstacles, the limitations, and understand the hype around AI. So just we can break them down on data, where we have limited access to data, limited access to annotation of the data, so many regulations, clinicians have limited time, productivity pressures, generate RVUs. Researchers also don't have much time, and there is a lot of pressure and innovation for the companies to put products out that might not be meaningful. And also culture, right? Among the patients, among ourselves, among others. And that gives us a huge opportunity to start understanding what's surgical data science. And if you think about that, the core of surgical AI is a surgical video. And the surgical video is created, this data, between an interaction of a clinician, a patient, a researcher, and an industry. And all of this is governed by so many policies, regulations, and oversights from societies, governments, ethics committees. That's how it starts. So if you're going to be treating this as video as data, we should also be treating it as a very, a serious data collection. For example, you get a tissue sample, goes to a container, go to a pathology lab. Likewise, a video should go to USB drive or to the cloud and go to an AI lab. So for us to see this happen, we also need to be very responsible and conscious about what's going to be the development of surgical artificial intelligence. So if you divide it in three buckets, one, the foundational work, what's based on annotation, data, and governance, there were structural needs, where the video acquisition frameworks, the management of the data through the life cycle, and also our knowledge creation and dissemination through scientific meetings, education, and of course, a cultural transformation of our colleagues and ourselves as well in the society. So to go over a little bit of each one of them, for the foundational work, data is divided on data structure, which goes from its format, management, access, deployment. The use, which are the users of the data, which are like pretty much everybody, from the physician to the hospital to the patients, to researchers and corporations and media. And of course, the governance of the data can range from our IRBs to HIPAA, ethics committees, regional state, Consumers Private Act, or even like a continental one, such as GDPR in Europe. Other thing that's important to understand, what are the ethics that are watching all those principles in AI? Very elegant paper published by Harvard Law, where they are looking about the key principles on AI in every single publication that was pertaining to artificial intelligence. The interesting thing here, there is none on surgical AI, which gives us a huge opportunity to start playing on this field as well. Next, the annotation of the data. What it is how we label what's happening. For example, this is a Tesla autopilot. And what you can see, the bounding boxes labeling visually what are in car, pedestrian, signs, and also actions are occurring. The car is accelerating, is braking, is turning, so on and so forth. So there is spatial and temporal annotations, which is not different than surgery. For example, on the left side, you can see a temporal actions occurring. What's the cystic duct being cut, the gallbladder is being retracted, and now the cystic artery will be cut. And on the right side, the visual representation of those elements. So there was this paper was just published in Surgical Endoscopy. It was a official consensus statement from SAGES. This was based on an 18-month project where we get a lot of scientists from both clinicians and data scientists from academia and industry. No one that was not a researcher were allowed to participate on this. So there was like no CEOs, no marketing people. And we were able to come up to make recommendations for annotation framework for surgical video for the very first time. And the way we divided that was the special events. And when you imagine that the hierarchy going to be the regional anatomy, the upper, lower abdomen, for example, the general anatomy, veins and arteries and muscles, the type of tissue that will occur frequently in different parts of the body. Specific anatomy, such as the common bile duct or like the liver itself or the stomach area. And tissues characteristics, such as are normal tissues and abnormal for edema, tumor, inflammation, so on and so forth. And if we create that in a hierarchical fashion that's expandable, look at this, we can create building blocks such as Legos that can be exported from one data set to a different data set. And we did the same for the temporal events, where the highest temporal level would be the phases. And they're generic, from the access to the execution of your objective, the procedure to the closure. They're under that are the steps. The steps are much more procedure specific. And a combination of steps, a sequence of steps, they are designed to accomplish a clinical meaningful goal. Under that, you have tasks, for example, task of suturing, which is generic, and under the task of the actions, you're twisting your wrist, you open your dissector, so on and so forth. Similarly, breaking down a laparoscopic cholecystectomy in a hierarchical, temporal segmentation phase. You can see that can be made in building blocks and export to different data sets, so you can actually compare large data sets. Following that, the scientific efforts are very important in the advancing surgical artificial intelligence. For example, computer vision challenges, where what it means is that you're being given a number of images, could be videos or pictures, where there is a question to be answered and algorithms have to decide that. For example, we are putting together through SAGES a computer vision challenge on the detection of critical view of safety for lap cholis, where it's going to be 1,000 videos coming from all over the world, and who detects the most is going to be the winner of that challenge. Multi-institutional collaborations, academia, industry, standards for publications, because a lot of the publications coming out right there, they just say AI and people say, oh, they're actually using AI, but technically we're not. So I think the journal should be looking with much more scrutiny about if the utilization of the name machine learning, artificial intelligence are actually being properly used. Validation studies, of course, and also should promote diversity like anything else. Education and training should come from scientific meetings. Soon you start seeing added to curriculum in the medical schools. Recently, I just gave a talk at Harvard for the medical students for the first time, explaining what's artificial intelligence and its implications for surgery. Dedicated fellowships at our institution, for example, we have a 2-year fellowship for both surgical residents and for PhD engineers on surgical artificial intelligence. And publications. We got to be publishing everything we come up with that's meaningful. Also, it's very important for us being responsible for a cultural transformation. We should be comfortable in sharing data. We should be comfortable in sharing knowledge, not just holding for ourselves. And cultural differences. And you really need to understand this because it's very important in artificial intelligence. This paper actually summarized that. It was called The Moral Machine. It was done by MIT Media Lab and published on Nature. And for the ones who are not familiar to it, I highly recommend you read it. Here, what it is an autonomous vehicle with 3 passengers about to get into a collision, either in a barrier or 3 pedestrians. And the machine has to make the decision what to do. And what we found was there was different all over the world. Some countries would say, or regions would say that they prefer to spare the lawful or the females or the young or the old, the rich. And like I was saying, artificial intelligence has its regional differences, and it's very important for us to adapt to those. Then other considerations you talk about is like who owns the data, this surgical video data or others? Is a patient, provider, hospital, payers, maybe all of them? Who gets the credit if there's a right decision made, or also who gets the blame? Would be the machine or the surgeon? And also, how could you explain to a patient that the decision was made by the machine and not by you or in conjunction? And could you challenge that decision? So for us to fix this and address all those limitations, it's very important to work in collaboration. Example of collaboration was this project for the surgical video annotation. More than 50 people here working together for 18 months. Followed by a second summit that occurred this year, what's the surgical video structure, where we were looking about the structure, the use, the exploration of the data, and the governance for research, clinical, and education purposes. Next year, on the sequel of those three, we'll be looking at regulations, policies, and oversight. It's probably going to be one of the biggest of them and most challenging to get people together, because we're getting also the government, malpractice insurance industry, payers, patients involved on this discussion. So, and to finalize this, also it's very important to understand that data management framework should be universal, allow for standardization for annotation and the structure, should have transparency and oversight of what's happening on this type of data manipulation, address the ownership, and promote collaboration. For the professional preparedness, think about computer sciences should start being added to medical schools, perhaps some courses for residency through the societies, discuss ethics among them. Perhaps our workforce might not be as big as what we need this day and age. Imagine if we have some robots doing parts of the operation, might be able to be supervising two at the same time. And of course, if you're going to be doing less surgery, you might be doing more simulation. And also have to have the credentialing of the hospitals. So that being said, for surgical AI to be scalable, sustainable, and a reality for us, all those elements should come together, and we should be responsible for that. And if you see something like this happen, imagine the potential that we could actually be creating a sharing of the global knowledge and resources that we have. Every time I learn something from my own mistakes or from an M&M meeting or for a conference such as this, I learn it once, and then I have to sleep and rest before I can go out to work next day. But the machine could learn for every single surgeon's mistakes and triumphs and put all of this together. So if sees something in China happen, it was super rare, and somebody then in Germany going to do the next day, if you have this collective surgical consciousness guiding us through the operation with unbiased, we'll be much better surgeons. Going back to that case that there was a complication, remember the machine was able to detect the complication and just tell you later that a complication occurred. But if you have a collective surgical consciousness behind us, we have the huge potential to then, for the first time, prevent complications before they occur and have a normal surgical fingerprint at the end of our case. That being said, I'd like to thank my colleagues worked super hard for all of this to happen. And I finish with this. Thank you again for the opportunity. It has been a great day to learn from others as well. Thanks so much.
Melis, that was a phenomenal talk, and it just amazes me. You know, obviously, I know nothing about AI. I mean, I can't get my Zoom to work, so AI is a distant dream. But we're just not even scratching the surface, and the possibilities for, I think, our patients are just so limitless. So thank you for that phenomenal talk. And we'll move on now to our last speaker, Dr. Hahn. Dr. Mary Hahn is the chair of the Department of Surgery at Stanford University. She has numerous leadership roles across the country in many societies. She's the director for the American Board of Surgery. She's also the chair of American College of Surgeons Scientific Forum Committee and a trustee and treasurer for SSAT. She's a long-time advocate for women and underrepresented minorities in American surgery, and her talk is about the same. Dr. Hahn. She's not with us today, but her presentation is with us, so we're going to go ahead and play that.
Hi, I'm Mary Hahn. I'm chair of the Department of Surgery at Stanford, and thank you for the opportunity to talk about this really important topic in surgical training and how do we create a more inclusive environment for women and minorities in the field of surgery. I'm sorry I can't be with you live today. I had something come up and actually I think hopefully on an airplane right now. Anyway, so when I think about why this is an important topic and why we still need to discuss it today. I reflect on this book that I read by Alain de Botton called Status Anxiety, where he talks about kind of our social anxiousness and how we feel when we enter into a community. How do we measure up? And especially in the United States, I think we have this myth that we live in a meritocracy. And a meritocracy is a society that believes only the talented and the most meritorious will end up at the top of a social ladder, and that everybody's given an equal chance to climb that ladder and has equal ability to climb a ladder. And I think it's readily apparent to all of us that we do not live in a meritocracy, and everybody doesn't come with the same chance and opportunity. So how do we as leaders help level that playing field and help give a hand up to people who haven't had all the opportunities, maybe say that some of their peers have had? So we don't live in a meritocracy. How do I know that? I'm just going to move this around, I think, so I don't cover up my slides, because advancement is still often based on who you know. Surgery is a really small world, especially academic surgery, and we rely on our network to identify people for residency positions, for faculty positions. And so definitely in our world, advancement is still based on who you know. When we nominate people for societies or for opportunities, as we often will nominate people we know because we know they'll do a good job. And I think our biases, implicit and explicit, can blind us to competencies that are present. I know, especially as women, we often get, well, she doesn't want to do this right now because she has a young family, and, you know, I wouldn't want to ask her and put that burden on her. And so I think we all have these biases, and we project on other people what we think they may be able or capable or wanting or willing to do at the time. And then I think similarly, our biases project competencies on others that don't exist. We often see ourselves in others, and then may apply attributes that we either see in a colleague or in ourselves in someone when they may not really be there. So I think bottom line is we don't live in a meritocracy. So if you, and then we think about, well, how there's a lot of work being done right now. Well, we can just use AI to, in machine learning, artificial intelligence. I mean, the computer isn't biased. Why don't we use algorithms and other mechanisms to take our implicit bias out of it? The problem is that the bias is interwoven through all of our data. So if you Google doctor, and like I did here, and you go on the little cartoon images, you'll see that about 80% of the images are of a male, and in particular a white male. There are a few females and very few minority, if any, images on this webpage of Googling doctor. Similarly, if you Google nurse, you get the exact opposite. It's primarily women images that come up, and again, primarily white women. So there definitely, I think, just using this as one way to graphically demonstrate the amount of bias that exists in our underlying large databases as well. So finally, if we Google surgeon, I actually think it looks a little better. We see many women and many probably minorities or different races represented on this slide. And this is just the top hit that comes up. So I didn't go down and compile this myself. So that makes me think maybe the field of surgery is a little more advanced, or maybe a little more explicit out there in what we think a surgeon looks like. So what can we do for each other, and particularly what can we do as leaders? And how are we going to combat and level the playing field? I think we need system solutions. So things that I think about doing is local at your own program for your medical students who are seeking to, through surgery interest groups, seeking interest in the field of surgery, that we create mentorship through surgical interest groups, that we don't have people leave before they leave because they're told by their colleagues or medicine residents or other well-meaning people that if you're a woman or you're a minority, you can't be a surgeon because of some reason. Just fill in the answer to that question, especially for women. It's like, well, you'll never get married, you'll never have children. And then I think we also need to have diverse selection and promotion committees with clear guidelines for how we select residents, what guidelines, what are the attributes that we're looking for, and then how do we amplify our candidate pool so that we make sure that we have adequate representation and even over-representation from underrepresented groups so that we can ensure that we make our field more diverse going forward. Nationally, for students getting involved in organizations like SSAT and the American College of Surgeons, other professional surgical organizations really welcome involvement of students early on. You're our future. We want to hear from you what's important to you and how we see ourselves going forward, because basically our surgical societies are membership services. People join our committees or join our societies because they want to have an affiliation with a group of professionals who have similar clinical interests, disease interests, academic interests, and be a support group and an opportunity to share ideas and come up with better solutions and how we advance our field. Similarly, in program committees, giving opportunities to students and residents to present, be able to showcase their talents and really give them an opportunity to meet with different leaders. The other thing I think that is really important to learn about is the difference between mentorship and sponsorship. A sponsor is usually somebody who you can have peer mentors, you can have people can reverse mentor. I have many junior faculty who I've received mentorship in different ways. But sponsorship is almost often somebody who has some type of positional leadership who can use their voice and influence to help lift up others. And a sponsee is somebody who's vouched for. So when your clerkship director vouches for you in a letter for a residency application, or your fellowship director vouches for you in a letter for either for a faculty position or an opportunity in a society, that gives the sponsee a leg up. Because basically your sponsor is using their voice and their influence to open a door for you. And it's really incumbent on that sponsee to deliver. So if somebody is going to not stick their neck out, but use their influence to help you, it's really important that you recognize that and that you follow through. So if you, usually they'll check with you and say, hey, there's an opportunity for you to be on the program committee, or I can put your name in for this job. Are you interested? It's good to be honest, because if you're not interested and you don't show up and you don't do a good job, that hurts both the sponsor and the sponsee. So I also think a lot about responsible sponsorship. I get asked for many, to nominate people for many different opportunities. And I also observe how other people use their position as a sponsor to nominate people. And sometimes I see people just kind of, they've got like a close network. They nominate each other. They only, it's kind of, you scratch my back, I'll scratch your back, and we'll each lift each other up. That's right. That's not a common thing, but it's definitely out there. So I think in order to be a responsible sponsor, you really have to consider so many different attributes when an opportunity comes along, to think really broadly about, who are the best people for this opportunity, who are people that I'm not thinking about. So really, before just quickly responding to a request, take a few minutes to really think about people who are out there, people who you've interacted with, people who you've heard about, and see if you can have the opportunity to elevate others who might not normally have somebody looking out for them. And I think, beyond race, gender, ethnicity, orientation, we need to think about geographic representation, disciplines. Oftentimes, an organization can be overweighted or underweighted in a certain specialty within surgery. Scope of practice for many of our organizations is really important to have people who are in academic, community, rural practice. So we really understand the voice of surgery and how we represent the interests of surgeons. Types of research that people do, so that We consider all types of scholarship beyond clinical and basic research to educational research, global health research, and so on. So I think just to wrap up here, I just want to, emphasize that we don't live in a meritocracy, and believing that we do is going to just disadvantage so many, but in particular our field. And so I think it's our obligation as leaders to lift up and create opportunities for those like us and for those different than us. And finally, I think when we observe sponsorship that isn't inclusive, it's an opportunity for us to reach out, raise awareness, maybe challenge and say, can you think of a few other people, a few other names that we could put on this list before we make our final selection? So thank you very much for including me in this important panel. I look forward to watching my fellow speakers' presentations once I land. And I hope everybody has a good rest of their day.
Well, thank you to Dr. Hahn and the rest of the panelists. Those are wonderful talks, and she's obviously very insightful and very passionate about inclusiveness of everybody in the world of surgery. Since we've answered some questions already, we don't have any right now, so I'm going to go ahead and ask a question while we wait for anybody else to ask one. My question is for Dr. Morales. It's kind of a little bit two-sided, but the first thing is, how do you foresee us sort of bringing AI into clinical work? Is it going to be something where AI helps us with segmental parts of the case? So I was thinking while you were talking about the case I did today, where I was doing a peristomal hernia repair, right? And so the hardest part of the case was probably the adhesiolysis, and then when you're ready to sort of sew in the mesh or cinch up the defect, maybe do you visualize us pressing a button saying, all right, go for it? And the AI mechanism can sort of do that. And the second question is, and you sort of alluded to it about the moral machine thing, right? The art of medicine side of surgery, and when we're making sort of real-time decisions on during our cases, and how do you foresee that being intertwined into AI? And I know probably both of those you could give our lectures on, but just very curious and very insightful talk that you gave.
No, thank you. Yeah, so very good questions. I would say for the first one, the implementation of AI, like in medicine and in surgery, we're already seeing some in medicine, right? Because they help us like risk, stratifications and risk prediction, or like readmissions and so on and so forth. Those are done by algorithms, right? But more specifically for the things we do, that we are so different than the other physicians, because with our hands, we can actually alter tissue and cure disease or make somebody feel better right away, sometimes feel worse. But for that, going from the intraoperative decision support to automation, that's going to be a long, long way. And what we're going to be seeing first, we're going to be just a machine kind of mapping what we are doing, kind of making the prediction of the time management for the operation, or like calling for the instrument that you need. Some of the companies are kind of doing that already, because let's say you do a lot of robotic gastric bypass, for example, and you have used like the same loads for forever. So the call is going to be, they're going to need 6 loads for that particular case. And you're about to do that. The next step, what's going to happen is going to be the inference in the prediction within the case. It's like, for example, I'm dissecting the gallbladder hilum, and then suddenly I have not seen the system, only 2 structures within that. The machine can say, pause for a second, stop, think about it. And sometimes, I mean, that's what we need, and say, you're right. I mean, I have not seen that. And the advantage of the machines over humans is that we have no bias against like our ways telling us, turning here over there. If you have our wife telling you, you've got to turn right and left, you're going to start yelling at. So instead of having a second eye of surgeons as a human, you have a machine there. But then what's going to happen is it's going to start evolving to the point that they're going to be able to get you out of trouble and just say, for you to get from this point A to point B, you should do that. For example, the mesh you mentioned, like say your mesh is too small based on the area that I'm seeing. I recommend you do that. You can always override the machine, right? And then lastly, the automation that I think we're going to see in our lives is going to be just subtasks. For example, you press the button, going to do the anastomosis, or going to fire the stapler, or going to something like that. You're really not going to be doing the robot in the entire operation. I can guarantee you that. And then to answer your second question is also go to the moral machine is going to be quite hard for us to discuss with the patients and say, if the patient asks us something to do, there's a lot of the human portion of that. Like, for example, I'm a bariatric surgeon. I always ask, make the smallest pouch you potentially make, or like I want to like my sleeve to look like this, and you just tell them, you just don't do that because you want. I mean, there is a rationale behind that. But the problem would be that then if you're being challenged by the machine about something that you still believe that you know better than this consciousness, how do you go about it, right? So perhaps like you may need like an arbitrage, like if something happens like this and another human comes and look at the case and discuss. The advantage of that, every time you have those curved balls, then the machine gets even smarter, right? But what I think is the most, probably the best, the most important like message I can give to our trainees right now is that to understand that we are so important for the development of this and so fundamental that we should start engaging ourselves right from the beginning and not just wait for a company to come and tell us, oh, I'm just implementing a new AI device. They're going to tell how well you're doing in your case. We should be the one coming up with those metrics, those assessments, and to move forward in conjunction with the industry, of course. Yeah.
Hi, Dr. Morales. I have one, we actually exceeded time, but I just have one quick question. And I'll preface it by telling us a very quick story. So when I was in training, we used to have a surgeon. He would tell us that there are two ways you can do this operation. You can do it my way, or I can do it my way. And I joke about it with the residents, and I call it the my way or the highway technique. The point being that obviously, I think we all appreciate that our trainees are fundamentally different, and they want and demand freedom to learn the way they want to learn. But we also appreciate that they require some structure.
Yes.
How do we strike that right balance between structure and freedom for the trainees so they can become the best surgeons that they can be?
Yeah, so I think obviously Dr. Mallinger and Dr. Zmink here probably could even answer this question better than I can as like their educators. But I think asking on the point of how to apply, artificial intelligence to do that is if we have our basis very well structured, our fundamentals like to be like the most pristine and precise. And then on the next level to be open-minded to understand that there are different ways to do an operation. And then the last thing will be the validation of the outcomes, if that is actually truly, the case. On the way over there, you can see what would be the ways to teach, the ways to train, which one's the fastest path. And at the end, I think all going to be, being leveled up, being the same field. But I think having our foundation very strong with core principles, benevolence, good technique, and be good surgeon, be good people. I think that's the most important. If you build that core on our base of surgical AI, whatever comes on top, there are plugins and there are upgrades and remixes.
Dr. Mellinger, Dr. Zmink, quick word on the structure versus freedom.
Doug, go ahead.
I usually defer to Dr. Mellinger on most questions. I'm not sure the structure versus freedom is that unique to this generation, honestly. I mean, I think generations before also didn't want the attending meddling in them doing the case. I just think it was a different environment and what they were allowed to do. I think that's our job as educators, is to give them just the right amount of freedom or autonomy to do the case. I honestly don't think the quote unquote good old days of the resident operating by themselves without an attending is a good way to learn. And I think, have we maybe gone a little too far overboard? Perhaps we have, and I think that's on us to figure out how to find that happy medium where we give them some freedom and some autonomy, but safely. And I think we can still do that. I don't think it means that the attending has to do the case by any stretch. But I don't think we want the old way where the attendings weren't around. And that my sense is that that's not necessarily a great teaching paradigm either. I didn't live through that, but and there may be others who feel otherwise. But I think we need to find that happy medium. And I think the key I think of, and I saw a question about this in the chat at one point, I like to break the procedure into components, and there are parts that, we, rather than say you're going to do the whole case, let's focus on certain aspects of it, and let's get you to do that autonomously. And then there are other aspects where I might need to help you, but next time you can try to do that autonomously. I think that's much more palatable for attending surgeons too, to understand, to break it into parts and try to give autonomy in certain parts.
I agree. We just finished our fellowship interviews, and I thought it was really interesting. The vast majority of the applicants asked about how much autonomy they were going to get. And I think they do get a lot of autonomy in our program, but I thought it was really insightful. The one applicant said, I'm not really worried about how much autonomy I'm going to get. I'm doing fellowship because I want to learn, from experts in this field how to do things. And it reminded me of once when I was actually a fellow. I was having a hard time throwing a stitch, this colorectal fellow, a difficult stitch in the rectum. And my attending tried to take it from me. I'm like, no, I can do it. And he said, I know you can do it, but I can show you a better way to do it. So I think that balance is really important. You have to struggle a little bit to figure out how to set things up and to figure out how to progress in an operation. So you need that autonomy. But at the same time, if you're struggling and not making progress, the whole point of training is to have someone else there to show you a better way to do it.
I'll just say briefly, my golf swing is testimony to the fact that you can learn lots of bad things if you aren't structured in your initial approach to learning. I'll leave it at that.
Well,
With that, I think, go ahead. Sorry. I was saying with that, I think we have to conclude the thing. I think we could all talk for the rest of the night and continue to ask you guys questions. You guys are true leaders in the field of surgical education and the future of where we're going to take it. So we can't thank you guys enough for being here. We're honored that you took time out to spend your evening with us, and it was all very insightful and super interesting. Thank you so much. Appreciate it.
I just want to thank LK.
So
I don't know, LK Sloan for organizing the webinars and doing such a fantastic job, and Marie Altieri, who chairs the Resident Education Committee, for her support. And again, privilege and honor to have all of you. Thank you so much for your time. Good night, everyone.
Thank you.
Take
Thanks.
care.
Bye-bye.
Good night, everyone.